Hi, I'm Dr. Jennifer V. Brown, your stroke specialist, and today we're going to talk about communication as it relates to the ankle foot orthosis. I hope you appreciate these pearls of wisdom. So, when it comes to communicating, especially from the perspective of the patient or the client, there has to be shared decision making. And this shared decision making is a collaboration between the orthotist, the physical therapist, the occupational therapist, and the caregiver who should be in full support of that patient or client. And the thing that we want to make is the most optimal AFO for health outcomes and better function and fit to do the things that the person desires. And so when we look at this, the AFO, the pinnacle or the top, has to align with the patient's or client's values, their preferences for not only what they wear, but what they do in their daily lives. And that has to mesh with the evidence and practice based options that the therapist and the orthotist know about, they have experience with. And the most important thing is that we have to be able to optimize the health outcomes of the client and make sure that they are getting equitable treatment. Everybody is different. You have to have precision rehab, okay, that aligns with who the patient is, their impairments. And just think of all these things that go with the social determinants of health, their economic status, their health literacy, the support that they have. When we can partake in shared decision making, then we optimize these two things: health outcomes and equitable treatment, which is really precision rehab for that client. So, clinical decision making becomes important because the clinicians, physical therapy, occupational therapy, and the orthotist have to be able to understand all of that neuroanatomy and what the lesion was and what the impairments look like. And then we have to be able to explain that to the client, how we are making the AFO so that it will impact walking, and then why a certain AFO is needed because of those impairments. And remember, we can do reps upon reps in walking, sit to stand, exercise, but if there's enough cortical spinal tract damage, we may have to do compensatory strategies that may not look normal, but the client can still function. And the reason why they need to participate in exercise and physical activity, because it optimizes their health outcomes. We may not always fix the stroke problem, but they can have a better level of recovery in terms of optimizing their health outcomes, like reducing their blood pressure, managing their blood sugars and their cholesterol levels, and preventing a second stroke. So, when we talk about communication, when I did some of these research studies, um, they had issues on how they were asked things and told things, the stroke survivors, that is. And some of the things that I heard over and over again, I didn't really have much say in it. Typical shoes, I was always told that I'd have to get one size larger and one size wider. No one asked me about what shoes I usually wear and what I like to do in them. They were all they I heard a lot of comments saying that, oh, what you have on probably won't fit with the brace. The issue is that we are not making the braces to fit the person's foot. We are making the braces based on a archaic model on how we make the brace, and it doesn't always come out looking like the person's foot and leg. And I've experienced this with the traditional casting models and with the scanning that they're doing now and the CAD CAM output of ankle foot orthoses made by the machines. So, the recommended solutions by the stroke survivors themselves was that number one, it needs to be a shared decision making for AFO fabrication, how it's going to be made, and what's the best option to make it for me based on my impairments. And again, we need to explain to the stroke survivor why they have those impairments and the chances of those impairments going away or getting better. We need to optimize behaviors so that they don't get worse. And then they want their opinions about their footwear, their choices in clothing, the activities that they do to be respected and valued. They want to be heard and say, well, we need to take into accommodation that you wear a dress all the time and a white plastic may not look good on your flesh tone and you want some color in that. And that we should be able to give that to the stroke survivors. So these are some clinical pearls of wisdom I want to leave you with. Is the person speaking being heard and understood? And that's just not the stroke survivor. That's the caregiver, the occupational, the physical therapist, and the orthotist. So how we communicate, we need to change it to whom we are speaking so that we could be heard and understood. And then we all need to come to some type of compromise. And then we need to explain the thought, the behavior, um, behind the compromising situation, I would say. All right. And so just be open to compromise. And I, as a physical therapist, have been open to compromise. People have told me, I can't do the exercises. I don't have time. It was too hard. I'm by myself. And it's really changed the type of exercise I give and how many exercises I give. All right. Everyone should communicate their hopes, their fears, their concerns, and their expectations. And I've really changed how I deliver why it's important to do the exercise. New graduate, if you do these exercises, you're going to get better from your stroke. And that's not necessarily always the case. The people will tell me, well, I was on the new step and I was back and forth and I was doing it and my walking didn't get better. Well, you probably need to practice the art of walking, but doing the new step didn't change the contracture in your ankle. And you're not going to be able to walk normal if you have a contracture in your ankle. And sometimes we need to explain those things. And then the last thing is be open to what is perceived as sounding negative. That negativity can be an opportunity to find a solution. So when my clients tell me, well, I can't do the exercises, then I have to ask the question, why can't you do them? All right. How is it that I can make the exercise different and more amenable for you to do in your home under different circumstances? And it works both ways that we hear or the person expresses something negative and it's perceived as negative, but it didn't mean to come out that way. So, in closing, I'm your trusted source for all things AFOs and stroke rehabilitation. Don't forget about the references. Alrighty? We have to have the evidence in order to do the best practice for outcomes that are person centered and make the best ankle foot orthosis. Thank you for listening to this video. Don't forget to like, subscribe, and share. Bye.